So welcome everyone. This is our 10th episode of our Pediatric Hospital Medicine podcast series. My name is Dr. Tony Tarchichi, coming to you from Children's Hospital of Pittsburgh here in Pittsburgh, Pennsylvania. Just as a reminder, I'm a MedPeds trained pediatric hospitalist. We've been doing this now for over a year. In fact, we just passed our 1-year anniversary. So before we get into it, let's do our disclaimer. So this podcast is for general, informational, educational purposes only, and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Like I said, we are here with our 10th episode of our Pediatric Hospital Medicine podcast series. Today is a great one. We are doing child abuse. We have been marching our way through the core competencies for pediatric hospital medicine. This one comes from the Specialized Clinical Services on Child Abuse and Neglect. I am very fortunate to be joined today by Dr. Rachel Berger. Dr. Berger is a professor of pediatrics and clinical and translational medicine here at Children's Hospital of Pittsburgh and University of Pittsburgh, and she's the head of the Child Advocacy Center here at the Children's Hospital of Pittsburgh, so obviously she's trained in child abuse, child advocacy. She recently served as the research lead for President Obama's administration's Commission to Eliminate Child Abuse and Neglect. So, Rachel, thank you for joining me today.
Thank you for having me, Tony.
So let's dive right in. Why don't we start by defining child abuse and neglect, and then we'll get into a little of the legislation. That is information we have to know as hospitalists according to our core competencies. And then we can really go into a little bit of the more clinically interesting parts of diagnosing this.
So as Tony said, I think one of the important things as a hospitalist is to understand a little bit about where the child abuse laws came from. First laws related to child abuse on the federal level are called CAPTA. And those were back in 1974. And CAPTA stands for the Child Abuse Prevention and Treatment Act. This has been updated numerous times since 1974, most recently in 2010. But really, the basis of child abuse laws in this country start at the federal level. The federal government then gives the rights to the state to establish their own laws. But the federal government, through CAPTA, establishes what they consider a lowest common denominator. So each state must define child abuse at least as strictly as the federal government. They can define it more strictly, but not less. So this is basically a minimum definition. And the federal government's definition is actually quite simple and I think very clean. And they define child abuse as any recent act or failure to act on a part of a parent or caretaker which results in death, serious physical or emotional harm, sexual abuse or exploitation, or any act or failure to act which presents an imminent risk of harm. And then each state defines maltreatment after that. You have to accept the federal definition in order to get what's called CAPTA funding. So there is some money from the federal government if your state follows these CAPTA rules. But there is significant variation from state to state about how you define it. For example, some states say for physical abuse you need to have substantial pain. Some say you need serious bodily injuries. Some say you need something beyond reasonable discipline. And a lot of these are very subjective terms. So as hospitalists and child abuse pediatricians, it can be very frustrating because you can have two children that live maybe 2 miles away but are in different states. So here we often have Pennsylvania and Ohio, where the two children can have the exact same injuries, but in Pennsylvania, which has a much more strict definition, it is not considered child abuse, and in Ohio, it is, even though it's exactly the same injury under exactly the same circumstances. So it's just important to recognize that different states have different rules, and the federal government gives them the authority to do that. Locally, there can be different interpretations of the same rule, which is why, for example, in Pennsylvania, we have many counties, each of which can have their own interpretations of the same state rules. So this creates, I think, a lot of difficulty for clinicians sometimes, and frankly also for child protective services workers who move from location to location because they can interpret the same laws in very different ways. There's one other important federal law related to child abuse, and that's called ASFA. And that was set up in 1988 and is really focused on child abuse prevention, adoption, and issues related to foster care. So ASFA stands for Adoption and Safe Families Act. So those two are really the most important laws related to child abuse. So people have to understand when reporting child abuse what their state law is and sometimes even what the local interpretation of the law is to understand how somebody might respond or how Child Protective Services might respond to a given report.
Let me ask you about that. Short of Googling the law, is there a convenient place to look for whatever our local interpretation is? As a hospitalist, from what you're saying, it sounds like we should at least know where to find this information. And I would honestly go to Google, type Allegheny County interpretation of child abuse or CAPTA. Will that work, or is there a place where it's much more convenient?
So in fact, the way the local authorities interpret it is not something that's in writing. It's just different interpretations of the law. But the medical definition, or what we believe to be reasonable suspicion, should not really depend on where the child lives. So I would say that if you believe something is child abuse and you have reasonable suspicion for abuse, you will be reporting it. Because our definition, we're going to define, for example, abusive head trauma. It's abusive head trauma whether I live in Pennsylvania or I live in Ohio. Whether this county includes that type of injury in their definition of abuse may be different, but as medical providers, we still should be reporting what is reasonable suspicion. But what's important is to recognize that the response might not be the same in different areas. But I would actually caution people against deciding whether or not they should report something based on what the state law is. So I think it's an important question, and the interpretation by a local agency is truly that. It's an interpretation, and it's not in writing. It's just that certain counties place more children in foster care. Certain counties have a lower threshold to remove a child, and it's more the way they're interpreting the law that the state has provided them.
All right, so right off the bat, the first one for knowledge for our clinical competencies for child abuse and neglect. Describe the aspects of the history and physical examination that should prompt an evaluation for child abuse or neglect, including specific patterns consistent with abuse, such as shaken baby syndrome, malnutrition, specific long bone fracture patterns, skin demarcations, and others.
So I think this first knowledge is almost the basis of a 3-year fellowship in child abuse pediatrics that most child abuse pediatricians have completed. So this is a very, very large topic, and there's no way to really focus on all of these, even this first knowledge, in just a short podcast. But I think that it helps in order to answer this question. We think about how do we help a child. What we really want to do is help a child who's potentially a victim of abuse. And in order to do that, the first step is to identify that there may be abuse. The other steps after that, which we're going to talk through in the rest of this podcast, are once you've identified it, how do you evaluate it? And once you've evaluated it and you decide to report it, how do you report it and do what we call the handoff to Child Protective Services so they get the information they need to properly protect the child, and how do you properly do follow-up? So this first knowledge requirement is a nice segue into that first step of protecting children, which is identification. So how do you identify abuse? And there are so many different ways that we need to identify abuse. And right now we're going to primarily talk about physical abuse. And clearly there are parts of the history that we've all learned as residents that should make you concerned. For example, a child who has injuries that are not explained by the history, or there's no history of no history of trauma in a child who has injuries. And then sometimes there are injuries that are not developmentally appropriate for that child. And then of course on physical exam, there may be injuries that we can see that we shouldn't have. And I think I would recommend that anyone who's really practicing in a hospital, in an emergency room, as a pediatric hospitalist, be very aware of the American Academy of Pediatrics statements about recognition of physical abuse. These are really nice, they're a clinical report about ways to help recognize physical abuse and when you might want to be doing an evaluation. Most cases, I suspect that children will have come through an emergency room where people will have already recognized that there might be abuse. Sometimes you may be the first person if you're undressing the child for the first time and seeing unusual findings. But I think the most important is the history, which we're going to talk about being very, very detailed in history, a very, very detailed physical exam, and then making sure those two match. And if they don't, then to think about the possibility that the history being provided is not correct and you need to think about child abuse.
So along the lines of knowledge, one of the things I'd like to try to do is look at what a pediatric hospitalist is reading to see if it's appropriate for this. So now, in the Pediatrics in Review in 2016, there was a really nice article on physical abuse in children. And then in 2017, there was 2 articles, one on child psychological abuse by Melissa Kimber and Harriet McMillan, and this was in November 2017, and then child sexual abuse in March of 2017 by Antonia Chisa and Edward Golson. And this is a good time to mention my usual disclaimer. I am likely going to butcher people's names, and I'm just going to apologize for everyone's names I mispronounced in the beginning, because it's just I just don't mean to. And then The Physical Abuse of Children from Peds in Review in 2016 by Jill Glick and Michelle Lorand and Kristen Bilka. After having read these, I felt like I reviewed the material from what I learned in residency pretty well. Would you think that that's a good base to start, or do you really think before someone reads this, they should have read the AAP's clinical reports, which there's a few of them?
I think these Pediatrics in Review articles are actually quite good, and I think that is a really good place to start. I like how the AAP has some tables that are very, very easy to read and really just make things simple and in a very tabular format. But these are all well written, and I think they're a really good place.
All right, so why don't we go to the next area of identify circumstances that may be associated with an increased risk of child abuse, such as poverty, family caregiver stress and isolation, intimate partner violence, special needs children, and substance abuse.
I think these circumstances bring up a really important issue. Clearly, there are risk factors for child abuse, and we know this through many, many studies. Poverty is clearly a risk. Caregiver stress is a risk. Isolation is a very big risk. Intimate partner violence, very significant risk, and the overlap with child abuse is about 30 to 60%, so that if there's intimate partner violence, there's a very high likelihood that there is also child abuse going on. Special needs children are at risk, partly because they have higher needs, and that increases caregiver stress. And substance abuse also clearly is a risk, and we've seen that a lot with the recent opioid crisis. Many, many more families and children being abused and neglected because of parents' addiction. So I think it's very important to know what these risk factors are, but also to recognize that there are many abused children who have none of these risk factors. And at the same time, to recognize that, for example, most children who live in poverty are not abused. And so I think that these are really important to know that although these are risks, not all children with these risks will be abused. In fact, the vast majority will not. And many children who are abused have none of these risk factors. And I think one thing that we've learned through many, many different studies and research is that we have to be very careful as practitioners that we don't miss child abuse because children do not have those risk factors that we perceive that they might have. So several of the large studies that have been done have shown that when children are white, when children have married parents, when children are from upper socioeconomic statuses, we tend to not identify abuse as well or as frequently as children who are not with those backgrounds. And that the threshold, for example, to get a skeletal survey, which we're going to talk about, appears to be much lower when we have children who are African American or from poor backgrounds. And as we're going to talk about, what's interesting is it's probably not that we're over-identifying abuse in African American or families with poverty, but rather that we are under-recognizing abuse in children who do not have the risk factors that we perceive to be risk factors for children who are abused. So I think we can't emphasize enough that although there are risk factors, most children with those risk factors are not abused, and many children who are abused do not have those risk factors.
All right, let's discuss the utility of radiologic and laboratory studies in the evaluation of suspected child abuse.
So again, I'm going to focus on physical abuse because that's where we're going to be doing most of our radiologic and laboratory studies. So at Children's Hospital of Pittsburgh, we have what's called a physical abuse power plan. And what this does in our electronic health record is really to give the physician an order set for multiple different scenarios in which you might be doing radiologic or laboratory testing. For example, if we have a non-cruising infant with bruises, which would, as you say, if you do not cruise, you do not bruise, those children should be getting an evaluation for abuse. We click on the sub-phase of that power plan or order set, and everything that the American Academy of Pediatrics recommends is pre-checked, and we just press sign. So all the testing that we need to do is there. That makes it very easy, and I would suggest that most people that are ordering tests for abuse on a regular basis have some easy way to remember. For example, when we have children with fractures that we think are potentially due to abuse, we will get vitamin D testing. However, our electronic health record has about 10 choices for different vitamin D tests, and we actually only want one specific one. So it's really nice to know what you need to order and make it very easy to do. So in terms of radiologic tests, the most important test by far, and probably the most underutilized, is a skeletal survey. Skeletal survey is recommended by the American Academy of Pediatrics in any child under 2 years of age in which there is concern for physical abuse. So that is a pretty low bar. Skeletal surveys, I say, are the most underutilized because we don't get them as much as we should. The yield on these skeletal surveys in terms of what percent are positive, in the largest study that was done, which was actually at our hospital, of 700 skeletal surveys, 11% of them were positive. That is far too high. This is a screening test, which I'm going to talk about, has very little risk. It should be far less than 11% because it shouldn't be that you need to do 10 negative skeletal surveys to get one positive. It probably should be closer to 50 or 100. So 1 to 2% of your skeletal surveys should be positive. So we are not doing enough skeletal surveys. Interestingly, data from the Pediatric Health Information System also suggests that the yields are much higher when they're obtained in Caucasian children, which again supports we are not doing enough skeletal surveys in Caucasian children because when we get them, they are far more likely to be positive than when we get them in African American children. So the skeletal survey requires at least 19 views of the different bones. You can do, depending on the age of the child, as they get slightly older, you need 2 for the radius ulna and then a separate one for the humerus. The young infants, they can get a single one. But the skeletal survey has to be at least 19 views. There is a standard American Academy of Radiology protocol, which virtually every children's hospital and hopefully most general EDs are using. And the threshold to get the skeletal survey whenever there's concern of physical abuse in a child less than 2 should be quite low. The radiation exposure from a skeletal survey is about 0.2 millisieverts. By comparison, that's about the same radiation as flying from one side of the country to another in a commercial airline. So that's a very low risk. And I don't think most of us would say we're not going to go to California this year because there's too much radiation. So I think we have to remember that as a risk benefit, whereas the benefit is identification of abuse, which allows us to then protect the child from further abuse. So skeletal survey, I would say, is the most important, and I would have a very low threshold to get it. As a hospitalist, you could be getting it when you have a child with any injury. Here at Children's, if we have infants with failure to thrive, where we believe that they are clearly due to neglect, we will often get skeletal surveys because of the overlap between abuse and neglect. So we do have a fairly low threshold to get a skeletal survey. Repeat skeletal surveys are also recommended by the American Academy of Pediatrics about 10 to 14 days after an initial skeletal survey, and that's because some of the fractures which are most specific for child abuse, specifically posterior rib fractures and metaphyseal fractures, are very difficult to see when they're acute and can often only be seen when they're healing at 10 to 14 days. So that's a very important addition that most people without a clear child advocacy center or child abuse pediatrician, you have to work out the logistics of how you're going to get those follow-ups. A study done here at Children's of Pittsburgh, interestingly, also showed an 11% positive rate on the repeat skeletal of unexpected fractures. Now, it's important to remember that not every child who gets an initial is going to get a follow-up, so it's a skewed view because we've decided to get follow-ups. But in quite a few cases, the follow-up skeletal survey made the diagnosis because at the initial presentation, there was, for example, only a bruise, which in and of itself is not going to be diagnostic of abuse. But then at the follow-up, we also would find a rib fracture, at which point now it is diagnostic of abuse. So they can be very, very important. The other important radiologic tests are going to be brain imaging, head CT, or brain MRI. At Children's, we've been using what we call a fast MRI for about 18 months now. These are quick 6-minute MRIs, do not require sedation, and do not expose children to radiation. And we pretty routinely use those in children who have a negative skeletal survey, do not have symptoms of a brain injury, but we're screening for abusive head trauma in very young infants, like a 3-month-old. People used to do bone scans to evaluate for child abuse, but this has really become much less common. There is a lot of radiation in a bone scan, and the follow-up skeletal survey should be able to show you what the bone scan could not. The only real indication for a bone scan now is if you cannot ensure a child's safety, and the result of that bone scan will decide what happens with the child in the time between the skeletal survey and the follow-up. But I would strongly suggest you talk to your radiologist and see if there's any other way, because a bone scan, I said, is fairly invasive. You need an IV, it takes multiple hours, and it's a lot of radiation.
Can I ask, Rachel?
Yeah.
If you're at a site without a fast MRI of the head, would you prefer sedation for a regular MRI of the head, or is a CAT scan of the head appropriate?
That's a really good question. So I would not recommend sedation with a brain MRI. We would recommend a head CT. And in fact, most hospitals at this point are still doing head CTs. It's a fairly narrow group of children who you're going to get imaging on where you do the fast MRI. It's a child who's generally under 6 months of age, where there's concern of abuse, and they're not acutely symptomatic of a head injury. But head CT, there is obviously radiation, but the risk benefit is still in the direction that the benefit is far more than the risk, so we would still recommend a head CT. The last radiologic test that I think might be used, and we use it rarely, but in very specific circumstance, is the chest CT. And we've really used this chest CT a bit to replace the bone scan. If we have a skeletal survey where we think there may be rib fractures, but it is very difficult to tell, and the safety plan for the child will depend on whether or not there are fractures, we will do a chest CT of the few ribs where the concerning lesions are to determine whether they are in fact rib fractures, because chest CT is actually far better than a skeletal survey in terms of seeing acute rib fractures, except that there's much more radiation. So by limiting where we're doing the chest CT, we can get the benefit of the chest CT without all of the radiation.
Oh, that's good.
So I think those are the radiologic tests that would most frequently be done. In terms of the laboratory tests, again, the American Academy of Pediatrics has some lab studies which they recommend. Our power plans include a combination of what our trauma service wants when we have children with trauma, plus those tests that the American Academy of Pediatrics. So our trauma team wants lights. We don't need them for child abuse, but they want them for their trauma team, so they're part of our power plan. And obviously, if you're taking care of children who are abused with a trauma team, you want to make sure that there's agreement about what that team wants and what you would want to evaluate for abuse. From an abuse perspective, we want to have a CBC with platelets, particularly if there's bruising, and we want to make sure that there's no potential underlying disease. We also want a PT-PTT. In the case of bruising, the American Academy of Pediatrics recommends certain tests, such as von Willebrand's panel. In the possibility of an abusive head trauma, they have other recommendations, such as certain factor levels. So I think that for your hospital, I think it's best if there is a clear list of what the testing is recommended by the AAP to make sure that those are consistently obtained. Similarly with fractures, we're not going to get tests for bleeding disorders. We're going to make sure that the vitamin D is normal, the calcium phosphorus is normal, that there is normal bone health if we're going to diagnose fractures that are due to child abuse.
You're just ruling out potential medical causes that could present similar to the abuse, which is the reason for all of the testing.
So I think it's an interesting question of exactly why you're getting the blood test. People often say, what are things that mimic child abuse? And I think I call that a differential diagnosis. I think in the court of law, people often call them mimics. But if I have a child with unusual fractures, in my mind and the way I explain it to families, there's a couple of possibilities, right? One is there's something very different about your child that caused these to happen when they wouldn't happen in a normal child. Like you said, the child fell off the bed and they have 4 fractures. So is there something different, like your child has a bone disease, they have OI, they have a vitamin D deficiency? Is this a freak accident, right? Where it's just something we've not seen before? Or did somebody hurt your child and this is not the way you described it? So I think if you have that as the differential diagnosis, really in any case, is this abusive? Is it accidental? Or is there something different about this child, i.e. they have an underlying disease? You're going to always look for those different possibilities. Clearly, in some cases, you're going to get the screening tests. If those are negative, you're done. In certain cases, you may say, the screening tests are negative, as with any disease, but I want to go further. Like I might get that OI test just because this is a little bit different. There's something unusual here. There's another family member who had multiple fractures. So I think as with any other disease, I think we just need to think about what the differential is and what the other diseases are that could present with the same signs and symptoms. Similarly, though, if I have a child with an abusive head trauma and several fractures, I'm not going to go get an OI test because that constellation of sign and symptoms is not caused by OI. So I think often people refer to as mimics, and I think about it more as this is what I would do for any other disease. And as a hospitalist, in any other disease process, you're going to think about what are the potential other diagnoses that I could be missing. And so I think about it in that way. Very rarely, so a lot of people will say, are you doing this for a medical purpose or are you doing this for a legal purpose? I very, very rarely will do something for a legal purpose. If a court orders us to do something, I have said no, but most of the time, if a court says we need this test for X, Y, and Z, we will get it, but that is very rare. So I don't tend to get testing so that I can say in a court of law that a child doesn't have a disease, but I recognize that some of my colleagues live in areas of the country that are much more litigious, and I know that some of them really do need to get far more testing than we get because of the local community environment as it relates to defense attorneys, defense experts. So I think there are tests that we need to do for medical reasons, and then how many tests you're going to do for medical legal reasons depends more on your local environment.
So the next one's broad, so we may try and shorten it, but list and discuss different medical diseases which may mimic the presentation of child abuse and neglect. This could just be the Nelson's textbook of pediatrics, but I'm going to give you the microphone.
I think you're right. We could list and discuss many medical diseases that, when I say mimic, though, really I'd say are part of the differential diagnosis of child abuse. And then we have to recognize that there are some cases that there is no other explanation. And this comes up a lot where people say, well, child abuse is a rule-out diagnosis, right? And I say, actually, it's not. Because if I say I am absolutely sure this child has child abuse, it is no different than I say I'm absolutely sure this child has diabetes, right? It's a medical diagnosis. There may be things that are on the differential diagnosis, but once those are not on the differential diagnosis, I have a diagnosis, right? And there's sometimes where, from the very beginning, there is no other explanation. We know from the start, there's nothing that looks like this except child abuse. So I think, of course, there's many, many things which mimic or can look like child abuse potentially that should be on the differential diagnosis of child abuse or on the differential diagnosis in a case of suspected child abuse. And these are always important things to look for, to think about. And as time goes on, we may find that there are other diseases that we've never seen that may look a little bit like child abuse, and we also have to consider those. But in the end, I think the thing that we have to remember is children have to be made safe while we evaluate for more of the zebras. And so sometimes the answer is, I don't know. This might be a very rare disease. This could be a platelet dysfunction, very, very rare, right? And the hematologist can't tell us for another couple of months if that's what this is. It's in the differential. And then Child Protective Services has to understand that it doesn't mean we can't protect the child while we work through these diagnoses. So I think we have to be careful that we don't say to Child Protective Services, well, we've got lots of things that are potential mimics, because the way they hear that is it's not child abuse. Whereas for us, we hear it as it's probably child abuse, but we got to make sure it's not a couple other things. So I think that's one thing I'll talk about when we talk about a handoff, why it's important what we say and how we say it to Child Protective Services.
Now, how often when you're doing the workup in patients that are not slam dunk, this is an obviously child abuse case, does something medical come up? And that's so subjective, you don't have to give me, but roughly.
So it's an interesting question. And a few years ago, we actually looked for, I think because it came up in court, we looked at what % of the consultations that we do that we feel are definite abuse, definite or probable abuse, possible abuse, and not abuse. And I was surprised to see that actually half of the time that we're consulted, we feel that it's simply not abuse. About a third of the time, we feel it is probable or definite. About a third of the time, we feel it's possible. And in our mind, we think that means there could be an alternate explanation. And mostly it's a freak accident is the alternate, not that there is a medical problem. We do have a case, for example, of OI every year or two, although most of those cases, frankly, are cases where there are many other parts of the history and physical. Like you're looking at the mother who's 4'7", who says, I've had 11 fractures. And looking at her, she's an undiagnosed OI, right? So the cases that come up that really are these mimics have, for the most part, been very, very obvious. Similarly with bleeding disorders. So although we do see mimics, I'd say several times a year, there are many other things about the history, the family history, and the medical history that make it clear that this case is different. For example, the injuries occur in a public place where you say, well, that doesn't really make sense. How did this happen, right? There's something different about this situation. We've had quite a few children with very low vitamin Ds recently also. And those were actually picked up in one case by our orthopedist who said, I've never seen a fracture like this in my whole life. It's a really weird looking fracture. And in fact, the vitamin D level was 4, right? So I think in that case, it wasn't just that the child had a fracture. It's even that this fracture looks different. There's something different about this fracture. And by the way, the vitamin D is 4. So I think it's fairly rare that there's medical diseases that we are totally surprised that come back positive.
All right, so let's get into discussing the cultural differences in the treatment of ill children that may cause unusual physical examination findings, such as coining.
So I think when we talk about cultural differences in child abuse, and we hear this a lot, we often hear the coining, the cupping, but I think we have to understand that I think the one we see most commonly is physical discipline, and what's the cultural difference in physical discipline, and what is culturally acceptable and culturally not. And I think what cultural is what is along the spectrum of what is culturally acceptable, where does it become child abuse? The one that's most obvious, for example, is genital mutilation, right? So we agree that is a cultural difference, but we do not accept it in this society, and we call it child abuse. And at the same time, there are cultural differences in physical discipline, and we draw a line, whether it's arbitrary or not, it's where we draw the line that this is not a cultural difference, this is now child abuse. So I think when we think about cultural differences, that some of it is clear differences, coining, cupping, but I think most of us would recognize those, and those are not done. Those are done to heal. They are not painful. They actually don't meet the definition of abuse. You just need to recognize that this shape is not a shape of something abusive, that this is a cultural practice. But I think the ones we really need to think about is where do people's right to exercise their culture end, and we as a society decide to define something as child abuse.
How difficult of a conversation is that if you have somebody from a culture where physical discipline is the norm, spanking, whatever it is, and then now you're called in because they've done that to their child, correcting them for one thing or another, and it is being called child abuse. And in the media, the most famous recent example, Adrian Peterson, for instance. I don't want to get into the specifics of that because we didn't take care of him, but you have a situation where this is a cultural norm, how the person grew up or where they're originally from, and let's say they're immigrants. How do you address that?
I think that's a really good question. And interesting, as a child abuse pediatrician, I was looking at all the comments that came back into the New York Times after that because I was looking to see where we were culturally. And I have to say that it's interesting. I have visited Sweden many times, which is a country which made corporal punishment illegal back in the 70s. And now if you look at the culture, the only people that will physically discipline their children are immigrants. And interesting, within about one generation of moving there, they do not use corporal punishment either. That they are able to successfully change from a kind of where the cultural acceptability in that culture is physical discipline, and within one generation, those people do not use physical discipline on their own children. So we can actually break the cycle of using physical discipline when it's considered a cultural norm, Sweden being the opposite example. In the Adrian Peterson case, it was interesting because if you look, most people agreed that he had crossed the line of what was culturally acceptable into child abuse, mostly because of the implement. And that's where a lot of people will draw the line. Spanking your child with your hand is still culturally acceptable. It's considered reasonable discipline. There may be reasons you don't want people to do it because of a lot of literature about it's not good for children, but people would not consider it in any state physical discipline to slap the child with a hand. But most states would consider using an implement to be physical discipline. And most people consider not having clothes on while you use that implement also to be physical discipline. So it's interesting that the responses actually to that specific case, actually people did feel that that had crossed the line. 20 years ago, I don't think you would have had that same response. So I think culturally, we also have moved our line as to what's culturally acceptable. When we have families, when I see families where there are cultural differences, or they will say, my parents beat me and I turned out just fine, I'll often move to other non-abuse related topics, such as when you came home from the hospital, you were sitting on your mother's lap in the front of a car, right? And it's true that you didn't die in that car ride home. However, how did you bring your baby home, the one that we're talking about, when they came home from the hospital? And virtually everybody will say, well, of course they were in a car seat in the back, right? And it's just an example. And when you rode your bike as a child, did you wear a helmet? And almost none of them will say yes. But if you ask them now, they all know they should. And actually, spontaneously, many will tell you a story of a friend who died or almost died in a bike crash or in a car crash. And so that kind of moves it to this is not different than other cultural norms, which over time we know better and have changed. So I focus on the fact that I understand this is what your parents did to you. And there are many other things that they did that we now know are not the best way to intervene with children's discipline? What else have you thought about using, or what have other people suggested? And I kind of move them into, this is not different than other things that you do differently than your parents. And I often will ask them also, what do you do differently than what your parents did? Or what did your parents do that you hate, that you said you would never do with your children? And interestingly, many of them will say, I said I would never beat my child, and I don't want to do it. So I think the conversations are difficult. You don't get 100% of the people, but I think you are able to move the dial a little bit and help people understand why you have now crossed the line. Of course, we're mandated reporters, and you're still going to report. And right? So you're going to say, this is considered child abuse here, and you're in this country, you're going to need to learn different alternatives for discipline. Here are some options. And if you report to Child Protective Services, they're going to be doing the same. They will try to find alternative ways for those families to learn how to discipline their children.
That was great. Thank you. Now, if you're keeping score at home, what we've been through, we are on the cultural differences. The next one is discuss the relationship between developmental stages of children and how these relate to accidental injuries, which I feel we've discussed. Would you agree?
The most important thing in terms of developmental stages is the statement that if you don't cruise, you don't bruise. And the younger the infant, the more worried you should be. The rate of abuse is higher. They're less able to protect themselves. But the developmental stages are very important insofar as children who aren't yet walking really shouldn't bruise, and they really shouldn't fracture very frequently unless it's part of an event where an adult drops them or they're involved with another person in some way. So I think the developmental stages are important, and they're also, as we're going to talk about documentation, really important to document as you're thinking through, is this history consistent with the injuries?
The next one is identify the requirements for and steps involved in mandatory reporting of suspected child abuse to the local or state child protective services.
So this is what we kind of call as the handoff. This is when we are reporting child abuse, we have to get the information from us, the medical people, to Child Protective Services, the completely unmedical people. And this is probably the most difficult part of protecting children. We talk a lot about identification of abuse, evaluation of abuse, whether you have to report, but the actual handoff, I think, is where most of the misinformation occurs. And we think about in medicine how well scripted our handoffs are. We spend a lot of time figuring out the best way to sign out patients so the next person knows. The difference in medicine is I'm signing it out to another physician who has a medical background and the same background as potentially as I do and as much or more experience than I do. In this situation, you, a medical person, are handing off often complex medical information to somebody with a college degree, sometimes a master's, sometimes, just out of college with an economics degree who passed the civil service exam, right, who doesn't know anything about medicine and almost never has children because the average age of the Child Protective Services workers is about 22 or 23, right? So the idea of doing that, when you think about it that way, you recognize how important it is to make things clear. They don't know that an ecchymosis is the same as a bruise. In fact, you can say they have a fracture and they'll come back to you later. So was the bone broken? Because they don't even understand that a fracture is the same as a broken bone. Right. And so we often take for granted that they understand what we told them and that they will make the appropriate decision, because the reality is they have the power to protect children. And aside from us taking protective custody, which is very rare and something you don't really want to do, we have no power, right, to ensure safety. So the people with all the power to do what needs to be done to protect children are the ones that have the least amount of understanding and knowledge from a medical perspective. So the step that's most important is to explain and make sure that person understands. And I often will say, I want to make sure we're on the same page. Tell me what you understand. And that often clears up a lot of misconceptions. I said, I recently I will tell you, I filed a child line, which we use our child abuse report, and I wrote all about the retinal hemorrhages and the abusive head trauma. And then I talked to the caseworker and I was talking about shaking. She said, oh my God, this is a shaken baby? And I had written the term abusive head trauma, which is the term that we've used now for about 5 years. I talked about retinal hemorrhages and brain bleeding, and it didn't occur to me that she didn't understand that what I was saying was this was a shaken baby. And so it just shows that sometimes I've been doing this for a long time, and I sometimes forget that our terminology is not their terminology.
I didn't know their average age is that low. That really does help quite a bit. That's a low age. All right, so describe the state and local statutes defining child maltreatment. Now that we did. So we're going to move on. So we're cruising through these. Explain the local processes involved in a hospital admission, including methods and timing of consultations and screening exams for both physical abuse and sexual assault cases.
So I think this is a really important issue, and actually it goes to the next knowledge base, which is the roles of various consultants. So every hospital will have its own set of processes related to evaluation of child abuse. And a lot of it, I think, depends on whether you have a child protection team, whether you have a child abuse pediatrician, or whether the hospitalist group is essentially your child protection team. So I think that's very important. And also whether you're a trauma center, because if you're a trauma center, then trauma patients, most of the child abuse patients, will be on the trauma service. If you're not a trauma center or a level 2, they might go to your hospitalist service. So I think a lot of the way that the process goes depends on the hospital itself and the local kind of setup of whether there's a child protection team and whether you're a trauma center. In terms of methods and timing of consultations, screening exams, skeletal surveys, head CTs, blood work, things that you need to make a decision about how concerned you are about abuse needs to be done sooner rather than later. And I think there's a lot of variability in where the decision to actually report is made. So in Pennsylvania, when you have reasonable suspicion, you are supposed to report relatively immediately after you have that reasonable suspicion. So sometimes I'll wait for a skeletal survey. If I have a child that has bruises all over their body and I don't need that skeletal survey, and particularly if there's other young children in the house that I'm worried about, I will file a report right away. Right? Different hospitals may do it different ways. We can file a report 24/7. We can also admit children while we're waiting for testing to come back. So I think the local processes, you really just have to know what they are. And the only things that are the most important is that reports are made, that you don't discharge children without ensuring their safety, right? You can't make a report of child abuse and then let the child leave the emergency room with the person who is the potential perpetrator, right? Until at least you've talked to Child Protective Services and made sure that, that's okay. Sexual assault cases is something we haven't talked about. We've talked mostly about physical abuse. Most sexual assault cases are going to be in an ER, are not going to be on a hospitalist service. And that way that sexual assault cases are evaluated is very dependent on a hospital. Some hospitals will have SANE P nurses like we do their evidence kits. Some hospitals will have physicians do their evidence kits. Some people will admit their children overnight and have the child abuse doc do them the next day. It's very, very variable. So the most important thing is that there is a protocol for how to do your sexual assault cases.
Could you go over, for those who don't know, what is a SANE P nurse?
So SANE are the sexual assault nurse examiners. That's a national designation. And there's SANE are adult nurses who have training in how to do sexual assault evidence collection. So that would be like an adult woman who comes in and has been raped. For the pediatric, there's a special pediatric training called SANE P. Those are generally SANE trained who then get an additional training as a SANE P nurse. Most adult hospitals have only the SANE nurses, and some of them are comfortable going down as far as about age 12 or so, and most people will transfer children younger than that who need a sexual assault kit.
Why don't we move into the role of various consultants who may be involved in an evaluation, like ophthalmology, radiology, heme, genetics, neurology, surgery, neurosurgery, and child abuse and protection team, which we've talked about, and then social services, trauma team, and Child Protective Services and others.
So I think child abuse is probably by its very nature one of the most multidisciplinary fields that there is. And sometimes when I explain, or almost always when I explain to parents what my role is, I say that my role is to take all the information coming from all the other doctors taking care of your child and making sure that there is a single voice going to Child Protective Services and potentially to police to make sure that they have a single message from all the physicians. And so there are so many different consultants are important. For example, an ophthalmologist is needed to do a dilated eye exam when you're worried about abusive head trauma. Radiology is really involved in every case, but not obviously directly with the patient, but with any radiologic studies that you get. And I said, we review every case with our radiologists, have regular rounds with them because that's such an important part of what we do. Hematology gets consulted when there's concerns of bleeding disorders. Child Protective Services obviously is involved in almost all of our cases. Genetics, if we're worried this is OI, if there's an underlying genetic disorder. Neurology is involved if a child's having seizures from abusive head trauma. But all these people have their roles, but their interpretation of the same findings may be very different. And I think it's probably most clear with neurosurgery. So as a neurosurgeon, I see a child with a subdural, and I say, this child is a subdural. I don't need to drain it. They are doing well. I'm going to sign off. There's no problem. If the Child Protective Services worker called that neurosurgeon and said, what's going on? They would say, oh, they have a subdural. It's fine. We don't need to do anything. Child Protective Services would take that to mean, oh, the child has a subdural. They don't need to do anything. It's not a problem, because that's what they were just told. Now, of course, they weren't told there's also extensive retinal hemorrhages, 11 fractures, and 3 bruises, because they asked the neurosurgeon. And from his perspective, if he doesn't need to operate, it's fine. So he's not, or she is not wrong, but that's their part of the case. So the child protection team physician, I look at as kind of the coordinator of all of these different pieces of information, and then with the expertise as a child abuse pediatrician to decide, is this likely to be abuse? Is it likely not to be abuse? And then how do I explain this to Child Protective Services? In our hospital, if we have any physician who does not agree with the assessment of the child protection team about whether it's abuse or not, we actually write that in our consultation, put their name, and recommend to Child Protective Services that they talk to that person. So if I think it's definitive abuse, and I know the orthopedist, for example, that doesn't usually happen, but I'm just giving that example, does not think it's abuse, I will say, these are my opinions. After consulting with all of my colleagues, this physician does not agree with this assessment. I would recommend you reach out to them. To make it very clear that although this is my opinion and all these other people do share it, there is one person who doesn't. So I really think that the various consultants, everybody needs to work together, but also we really feel strongly that our neurosurgeon, for example, shouldn't be talking to CYF because they are not recognizing how it's being heard on the other side. And we've had some situations, it's not neurosurgery per se, where a subspecialist has spoken to CPS, who have then made a decision that did not keep that child safe because they misunderstood the very narrow aspect of the case that subspecialist was referring to.
In hospitals that are smaller than these large children's hospitals like Pittsburgh, Texas Children's Hospital, et cetera, when you're at a community site or an adult hospital with a pediatric floor, so would the child advocacy or the child abuse specialist be as involved, especially if they're not mainly at that site, or would the hospitalist be the one performing the role that you're discussing now?
That's a really good question. And I think in most smaller hospitals like you're describing, often the hospitalist is essentially acting as the child abuse pediatrician and as the child abuse expert. Now, I would hope that most hospitalists would have the ability to call a child abuse pediatrician who is in their area, in their state, if they have questions. Most cases are going to be a bread and butter child abuse case, like most hospitalist cases are, but then there are the cases where you may need some more expertise. There are some states that have worked out systems, I think Indiana is one, where they have a group of child abuse pediatricians who actually offer expertise to anybody in the state who needs it. In our hospital system, UPMC hospital system, our child protection team is able to offer phone consultation to any of our 13 hospitals that take care of children and have questions about abuse. So I think you do need to find out what your local expertise is, and it depends obviously on your state. But yes, in many places, or your locality, in many places the hospitalist really is serving as the child abuse expert in that hospital.
So do you then would you transfer a patient? If there was a patient where there may be borderline, you're not sure, or they could be child abuse, and they're at a smaller site, a community site, would you recommend, or have we done transfers where we'll bring that patient to our hospital so you all can see the patient, so our specialists can see the patient? Or is it, if the appropriate specialists are there, phone consultation's appropriate, or is it different depending upon where you are, which is always probably the answer?
Yeah, it's different depending on where you are, but also what the situation is. So there are some times where another hospital, not that the child needs to be transferred, but they can follow up with our child advocacy center in our outpatient clinic, for example, where there's no acute safety concern. Child Protective Services has a place for the child to go. For example, their child has bruises, and it's unclear whether these are definitely abuse, they might be abuse. The person evaluating saying, I'm not willing to make a diagnosis, I'm just not sure. They're going home with a grandparent who's not the potential perpetrator, and we say the next day, you can bring them back to us, we'll get the blood work, we'll take a look at them, and we can help you decide. A lot of times if there's physical findings like a bruise or something on the skin, we do need to see the child. It's very hard to do it with photos, but it's something like a fracture, right? It's much easier to do without actually having to see the child. If the children are acutely ill, obviously we would transfer, but actually quite a few of these can be done without. And in the case of sexual abuse, many, many sites are using telemedicine so that either the person on the other side is doing an exam, and you're actually the expert is not the person doing exam, but the person on the other side of the camera, right, can actually see what's going on and seeing if the exam is negative, positive, or walking them through what they need to do. And that has actually worked very well, particularly in rural sites. So I think it's actually an area that's ripe for more telemedicine because a lot of what we do, you don't need to actually see the child.
Oh, that's interesting. I didn't know we're using telemedicine for that. Oh, well, you are.
We are.
You
many rural places
are.
Yeah,
Okay. So discuss the importance of proper, objective, written documentation in the medical record. And I'm actually going to take this a little bit of a step farther. Whenever I have a case like this, it's the urge to think of being in court. So there's that urge of, as I'm writing my note, to say, if they read this in court, is this written correctly? And I hate that because I want to write like I would normally write. But how important is that?
So I think of all the things on this knowledge, this is actually, I think, one of the most important ones. But I don't think I would have said that 15 years ago before electronic health records. So I think, while I don't think you need to write for court, what you write needs to be accurate. And with the electronic health record, what has happened is we will have a child who literally is intubated, sedated in an ICU, and it will say alert, well-nourished in under the general exam, right? That is harder to explain to a court than almost anything else, because the way that looks for a court is, you wrote this, you just defaulted, you don't even care enough to do this. How do I know everything else here is accurate? So I think we sometimes focus on, is every single thing exactly as detailed as we want? But actually, if at least it's fairly accurate and we have a skin exam listed, we've had children come for sexual assault where there is no GU exam listed, right? That's bad. That's bad documentation. When there are injuries, though, it is really important to document what you're seeing, where the injuries are. Photographs are sometimes worth 1,000 words, but actually they're better when they're just supported by your documentation, right? The location, how many there are, if you can describe shapes, things like that for things on the skin, that's very important. And pertinent negatives are actually more important, I think, in these kind of cases, saying the frenulum are normal. That's important because frenula tears are related to child abuse. It wouldn't normally be listed, like it's not a default, no frenula tear, right? But that would, for this kind of case, that's something that I would be very careful to document. So I think it's not that it has to be that much more detailed. It's just that I would be careful about defaulting on things that we don't usually worry about defaulting. And the other thing is copying and pasting, because it's something we do without thinking. And you can have a copy and paste through an entire medical record, and you get to the end, and it's nowhere near true anymore, but it's still part of the child's note. So I think I would be more careful than in other cases about copying and pasting. And in documentation of the physical exam, I would just be careful not to default to things that aren't true, and to make sure you have the skin exam listed, you have a GU exam listed if it's a sexual abuse case, and just be a little bit more careful. But it's true, it will be scrutinized in court. Every single part of that medical record, but not stuff that's not yours. And that comes up a lot. They'll put out notes from other people, and I'll say, I don't know what they were thinking. That's not my note. You'd have to ask them. But in my note, this is what I saw. So clearly, I did not see an intubated, sedated patient, and they saw an alert, awake patient an hour later. But what I can do is say, this is what I saw. I know I saw this, and you're going to have to ask them.
Now, here's where we get right into our roles. Explain the role of pediatric hospitalists in providing testimony in court, either as attending of record or as expert witness, as appropriate for the local context and training.
So again, I think this has to do with the local context.
Yeah.
In most places, or in many places, the person who goes to court is the person who's caring for the patient. In our hospital, our group, our child protection team, does most of the testimony, even when the patients are on a diagnostic referral service, partly because courts are not very conducive to people who actually have to see patients and see them quickly and are trying to round because they're very disorganized. And you could go have testimony any time during a day and they're not very organized. So I think it helps our other services. We keep our neurosurgeons in the operating room where they should be, as opposed to waiting for a call from court. But I think in some contexts, the hospitalists are going to be the primary people providing testimony. The question of whether you're doing it as an attending of record or as an expert, it is very rare for physicians to get called and not be asked for their opinion. To be just a fact, either a fact witness or an expert witness. A fact witness literally tells you, here are the facts, this is what the child said to me. But they can't say, so is the child a victim of abuse? That actually is an expert opinion based on all that you know. So most times a physician is called, you will be called as an expert because you've made a diagnosis, which means you have expertise. And people often say, I've never done this. Am I an expert? The definition of an expert in a court is that you know more than the ordinary person. Basically, if you know more than the jury or the judge, you are an expert. So every one of us is an expert. Some of us might be more of an expert than somebody else. Right. I could go in and be an expert on bronchiolitis, even though I know very little about bronchiolitis, but I definitely know more than the judge knows about bronchiolitis. So you do not need to know very much to be an expert. And any person who's a hospitalist is absolutely an expert in child abuse. It's part of our training. You are not as much as an expert potentially as somebody else, but maybe you are more of an expert than other people, who have not done as much as you have in this field. So most of the time, the reality is you are called as an expert. The time in our hospital where the child protection team cannot testify on the behalf of another person is when that child has made a statement to you and directly to you. Because then they didn't tell it to me. Right. And if that is the statement that Uncle Joe did this to me, you will almost certainly have to be the person who's testifying because the statement was made directly to you.
I did not realize the definition of expert in a court is that loose. So then really just about anyone listening to this podcast is an expert or likely could be an expert in a court of law. That's amazing. All right. So now the next one, this one's hard. It really will, just like everything else, be local, but list local community resources available if they're family caregiver and abused children, such as foster care, receiving homes, support groups, safe houses, parenting courses, and others. And I will say, CYF, so Children's Youth Services, depending upon where you are, is called something different. So where I was in Jersey, it was called DYFS, or Division of Youth and Family Services. So I guess knowing that, but what else would you think people should know in terms of resources?
I actually think this is one of the most important questions insofar as I said, most children we see, we don't think it's abuse, but it doesn't mean that I don't do anything. I think those are the families. It's not that they don't have risk factors, and there's a lot of things going on that they could use help with. It's just that it's not child abuse. And those are the families, and that's actually half of our consults, who could benefit from all of these local and community resources, which are provided in a very positive way because we're not calling Child Protective Services. So in a way, these kind of lists are actually more important because that's how we help families before their potentially abuse that we need to report. So I would suggest that if you don't have a list like this, that you work with social work to develop lists of what are your home visiting programs? How do you get into a WIC program? What are your we have family resource centers or family care connections. What are your local resources for families that are willing to accept help so that you have them available at a time when a family might be willing to actually accept them because something has happened to their child. So I think these are all important things. Where are your local domestic violence shelters? Very important to know because you might actually be able to help convince somebody at a time the child is not yet injured, but this is a really high-risk situation. Are you ready for this? So I think these are really important lists to have.
Is it safe to assume that just about any social worker in a hospital will have this list?
I think social workers do know about these. We work with a lot of general hospitals in our UPMC system where, for example, there aren't social workers in the emergency room at all. Some of them have very limited social work support. So in those hospitals, I do think that the pediatricians actually do a lot more with this because they have such limited social work.
One more question about the community resources, Rachel. So, we've had cases, and I'm sure everyone has similar cases, where the Children's Youth Services, DYFS, CYF, whatever you call them, in your local community, don't seem to do what you want or expect them to do for a child, and it's just flabbergasting. Can you shed any light on that?
Actually, I think that's a really important issue, and I think there's many reasons why they often do CYF or Child Protective Services doesn't do what we expect them to do. Sometimes it's, as we talked about, they don't understand the information we just gave them. So they're making a decision based on information that they didn't understand. That's sometimes the issue. Sometimes the issue is they know a lot more than we do. For example, as soon as we call in a case, they are going to see whether they've been involved with that family before, whether there's any outstanding warrants on people in that family, whether the police have been called for domestic violence, whether anybody in that home is an indicated child abuser. And sometimes they do things we don't expect because they have a lot more information than we have. So that's one important thing to remember. And the other possibility is that when they don't do as much as we would expect them to do, it's often because they are bound by their own interpretations, their attorneys' own interpretations of what they are able to do. So just like each hospital has attorneys, which help us, to make decisions about what we can and cannot do, Child Protective Services has plenty of their own attorneys and plenty of their own regulations about what they can and can't do. They cannot simply remove a child, for example, without a certain level of cause, or they will get sued. And there are many lawsuits right now against Child Protective Services for impingement on parental rights, where they removed a child that in hindsight they probably shouldn't have removed, and now they're being sued for it. And so they have many of their own rules and regulations and interpretations of those that sometimes limit what they can do. And even though a caseworker may want to remove a child, they are told you cannot, you do not have enough evidence, or a judge may overrule them. So Child Protective Services, we've seen this not infrequently, they will remove a child, they will go to court, and the judge will overrule their decision and return the child. So there are many, many different people at play here that we don't see, and we only see the very little part that we report. So while I think we can do whatever we can possibly do to improve that handoff, there are some things that we just don't have control over. And I think that's very hard as physicians, as long as I've done this, to just lose that control.
That's good to know. That was helpful to shed light on some of these things. If you're keeping track at home, we are through the knowledge section. We have covered half of the skills section, and we're heading into the home stretch. Now, let's talk about evaluating children who are failing to thrive for psychosocial contributors to the malnutrition. And this is something we see in hospital medicine a ton. Our diagnostic group still have an outpatient clinic where we see these children on the outpatient side. So this is helpful.
I think the fact that we're bringing up failure to thrive is actually interesting because, as Tony knows, in our hospital, our diagnostic referral service sees the vast majority of the failure to thrive. And actually, our child protection team gets involved only very rarely. And I often have to explain this to Child Protective Services. They sometimes think that we refer all failure to thrive. And I try to explain to them, we see failure to thrive all the time. We're only referring to you when we have done everything we can possibly do. We believe that there's no medical cause and that this is because of failure of a parent to feed a child. So I always explain to them, this is not what failure to thrive is. You're seeing a very thin slice of our failure to thrive. But I think in the case of children that we're worried about failure to thrive, where we believe that there's a psychosocial contributor, primarily that the parent is not feeding the child for whatever reason, whether it's mental health, parents have a drug addiction, they're not able to take care of the child. Admission to the hospital is by far the easiest way to resolve this issue. Now, unfortunately, with older children, it can be very problematic because, as we all know, it takes longer for older children to gain than for young children. But for very young children, the 3-month-old, the 4-month-old, in admission with a clear showing that the weight goes up while in the hospital is the easiest way to show that it is failure to feed, not an underlying medical condition. And from a Child Protective Services standpoint, that is the easiest way to go before a judge. The child was not failing. We've done all these things. We put them in the hospital. We did no intervention other than feed the baby. The baby grew. This child was not safe where they were, right? So the admission, although expensive, in the end is actually, I think, probably the best way to resolve the issue of whether it's psychosocial. I think there's a lot of variability about what people do to evaluate medically. From our perspective, from the child protection team, we very rarely ask for any tests. We just say feed the baby, and if the baby does well, then you've got your answer.
And from our end for that, we don't consult you for all of our cases. Though we really, there are cases where there's breastfeeding issues versus bottle feeding issues, and the mother just had to be shown that, breastfeeding's not working, we have to do bottle or something like that. But if there is an inkling of concern that this is a pure for the parents are not feeding, and this isn't an understandable cause, that's when you want to be consulted, right?
Actually, I think if the hospital, as a hospitalist, is comfortable doing the whole failure to thrive case without a child protection team, I think that's completely acceptable. I don't think we get involved even in all the failure to thrive cases that you report to Child Protective Services. So in our hospital, every report to Child Protective Services needs to get internally routed essentially to the Child Advocacy Center because of certain laws about the fact that they all have to go to one place. But we are very comfortable. If you're comfortable taking care of these kids, reporting them, testifying, and doing everything you need to do, I don't think we need to be involved. I think we often get involved because sometimes the follow-up is difficult when there's multiple physicians caring for the child. I think sometimes it's easier, just for logistical reasons, to have the child protection team come in. And I think there are other reasons why sometimes people will involve us and sometimes they won't. I'm very comfortable, if you're comfortable and your group is comfortable, that we don't need to get involved.
All right. This next one's a little out of date, so I'm going to correct it for the change. You'll see what I mean. Recognize abuse in children presenting with injury and unexplained symptoms such as BRUI, brief resolved unexplained event.
So I think this is a really good skill insofar as one of the groups of children or infants with missed child abuse are children who present with unexplained symptoms such as BRUI. So I think the child abuse as an etiology of the BRUI, it needs to be part of the differential. A low threshold to do a skeletal survey in children with a BRUI, particularly when it's apnea, and likewise a head CT, is very important. And similarly, thinking about abuse in children who present with other unexplained symptoms such as vomiting, irritability, fussiness, symptoms which are clearly soft neurologic signs and which, when accompanied by a history of trauma, you would clearly put child abuse in your differential. But we sometimes forget because there's no history of trauma. So the vomiting infant without diarrhea all of a sudden starts vomiting, not a good reason, does not develop that diarrhea, does not have a fever. We just need to think about, is that a child with an abusive head trauma? I think always keeping it in our differential, particularly for these admissions. We often talk about vomiting where we think they have pyloric stenosis. They get the ultrasound, it's not pyloric stenosis. To step back and say, okay, why is this baby vomiting? Right? Just because we've ruled out pyloric stenosis doesn't mean we need to send them home. We just have to step back and say, okay, what are other potential causes?
Recognized fracture types on radiographs that are suggestive of child abuse.
I think this is about 3 months of a child abuse fellowship on this question. But actually, the American Academy of Pediatrics, in one of the policy statements, has a very nice table of fractures and whether they are highly specific, moderately specific, or low specificity for child abuse. It's a nice table, but it's also important for us to remember, although there are a few highly specific fractures, sternum fracture, scapula fracture, posterior rib fractures, digit fractures in children under 1, those are highly specific, but the vast majority of fractures that we are going to see are low specificity fractures. The humerus fracture, the skull fracture, those are low specificity, but they are the most common. So recognizing fracture types, I don't know that you need to recognize whether it's a Salter 1 or what kind of supracondylar fracture. I think we can leave that to our radiologist, but recognizing once they say what kind of fracture it is this a fracture that is highly specific, moderately specific, not very specific, but most importantly, no matter which of those it is, does it match the history, right? If a brick just fell on the 2-month-old hand, I understand that finger fractures are highly specific, but we have a history. The question is, why did that brick drop on the hands rather than, are those fractures themselves highly specific? So I think working with your radiologist, very important. And I always keep that table in mind just because we should be worried about things that are highly specific, but recognizing, I think I've seen one scapula fracture in 10 years. It's a very rare fracture, but it is very specific.
And for those of you listening, I'm going to throw up on the podcast for the CME section, if you take the CME portion of it, all the references, including the AAP, clinical guidelines that we've been talking about, along with the Peds in Review articles. I'm going to try to figure out a way to put the Word document on the podcast so you don't have to go to the CME. Now, there is one final thing for the skills section. There is something we don't agree with. So there's one skill that's perform a fundoscopic examination to screen for retinal hemorrhages in children with suspected abusive head trauma. So I'm going to let you explain, Rachel.
So I have a feeling that this skill came out of a study actually done at Children's Hospital of Pittsburgh, where we dilated the eyes of children presenting with vomiting who had pyloric stenosis, because we were studying whether they had retinal hemorrhages. That's where I'm thinking this came from. The reality is, if there's a child with an intracranial hemorrhage and suspicion for abusive head trauma, most centers would require both the neurosurgeon and the critical care physician to give approval for a dilated eye exam. And in the vast majority of places, that dilated eye exam would need to be done by an attending pediatric ophthalmologist. I don't think any of us are nearly as skilled as a pediatric ophthalmologist with a dilated eye exam. We probably don't own ret cams where we could take photos of those eye exams. And you really only want to dilate once in a child with suspected abusive head trauma, because you don't want to lose their pupillary exam. You only want to dilate once, and then also actually taking the pictures can be a little bit stressful. You only want to do that once, and you want it to be by the person with the most expertise. So I think there were a couple papers, our paper with the pyloric stenosis. There was another paper about whether non-ophthalmologists are able to dilate and recognize retinal hemorrhages. But I think those are in cases where you don't suspect abusive head trauma. You're just concerned about abuse. And I think that those papers we've now realized that that's not the place to go. The first place is to image the head. If the head has bleeding and you think it's an abusive head trauma, you would get a dilated eye exam by a pediatric ophthalmologist who is the most experienced person doing that.
That's great. This was great. We've reviewed all the core competencies for child abuse and neglect for pediatric hospital medicine. This was really detailed, and I really appreciate my guest, Dr. Rachel Berger, for coming and joining us for this a little over an hour to do this. Rachel, thank you very much for your time. I really appreciate it.
Hey, thank you for having me.
Now, for those of you at home, we're going to wrap up. Thank you all for listening and joining. We're going to wrap up. We'll do our ending. Please remember, if you want to get free CME credit for this, it is through the University of Pittsburgh. So thank you, University of Pittsburgh. Just go to the link at the bottom of the podcast, and you'll be able to fill out the form. It's free for everybody. I want to thank all of you for listening at home. I really appreciate you all listening and tuning in whenever I release one of these. I believe my next one will be after the new year. And then for acknowledgments, again, I'd like to thank my guest, Dr. Rachel Berger. I would like to thank the Diagnostic Referral Group here at Children's Hospital, our hospitalist group, for giving me the time, the ability to do this. I want to also thank Dr. Megan Keene Tarchichi, who always helps me with everything. And as always, if you have any suggestions, concerns, comments are appreciated as well, especially compliments. Please feel free to email me. I'm happy to hear anything. And if you have any ideas for a future podcast, please let me know. My email address, Tony, Tony.Tarchichi, Tarchichi, at chp.edu. It's Tony.Tarchichi at chp.edu. Everybody have a great holiday. Have a great new year. I hope you had a wonderful Thanksgiving, and we'll see you soon. Thank you.